Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show. The purpose of this podcast series is to help a person or their family member navigate the mental health system. Dr. Justin Capote is a psychiatrist with extensive training and experience in the field of detoxification, or detox as it is commonly called. For those who are not familiar with this term, detox is the medical detoxification of substances that safely manages the acute physical symptoms of withdrawal that is associated with stopping substance use. Dr. Capote, from your experience working with patients experiencing medical detox, can you explain what is involved in this process?
Sure. Thanks for having me. Well, it depends on the severity of the detox and the substance from which you're detoxing. There would be a different approach to someone who's detoxing from opioids, which is generally considered not to be life-threatening, but certainly uncomfortable, versus someone who's detoxing from alcohol or a benzodiazepine like Xanax, where there actually is a potential for a life-threatening complication such as seizure or very severe delirium. Depending on the degree to which these symptoms are present or interfering with that person's functioning from day to day, they may seek out treatment either in an outpatient facility, or if it's bad enough, they may head right to the emergency room. And sometimes detoxification would warrant hospitalization on the medical or surgical floors.
Let's say it's on the medical floors. Can you explain a little bit about how the team works? Because I think it's multidisciplinary when it comes to detoxing somebody, both through medical, as you mentioned, with seizures, and also psychiatry.
I guess it depends on the resources available at the hospital. Sometimes you've just got one primary medical team managing, and in other locations that maybe have a few more resources, you may see a substance abuse counselor. There may be social workers involved in your care that are savvy and know a little bit of the language of stages of change, motivational interviewing, things like that. So let's say it's alcohol, and depending on the degree of dependence, right? If someone comes in and they're in their early 20s and they sort of drank too much one weekend and they were brought in by friends because they were sort of non-responsive, that's someone that's probably not getting hospitalized. They may just be observed overnight in the emergency room to see if any symptoms of withdrawal develop the following day. If it's somebody who's not sort of a regular drinker, contrast that with someone who perhaps is middle-aged, maybe in their 50s or 60s. They have a long history of daily drinking, and they come in seeking detox maybe day one or day two after their last drink. That's someone that may warrant hospitalization because their withdrawal could just from one day to the next really take off and put them in harm's way.
And that could include physical symptoms like nausea,
right,
seizures, heart problems. Something with the curve you described.
The QT interval?
Yeah. Does that happen with alcohol?
No, it's really more QT prolongation is going to be a risk if with medications you're giving the person.
Okay.
Depending on what you're giving them, some antiarrhythmic, some blood pressure medications, a lot of psychotropic medications, methadone. These are things that can prolong the QT interval. And if you're really leaning on those medications like methadone, I remember a case when I was training, somebody had lied about their dose of methadone. They said they were on a much higher dose than they actually get. The person overnight didn't confirm that dose because they couldn't. It was overnight. Winds up in the ICU, gets the dose of methadone he'd requested, and actually wound up with Torsade, which is an arrhythmia that could be fatal. And he bought himself a ticket to the ICU as a result of lying about his methadone dose. I remember that.
Will the doctor or the psychiatrist or the medical team prescribe in terms of taking them off of their alcohol, let's say?
Yeah, right. Again, it depends on what they're detoxing from. So, the two most common are going to be opioid withdrawal or alcohol/sedative withdrawal. So if it's the alcohol type, number one, it's the history. Are they symptomatic when they're presenting? Are they already demonstrating headache, nausea, vomiting, shakiness, tremors, high pulse? Are they still intoxicated? I can't tell you how often somebody come in looking for detox, still loaded, and they're started on this detox protocol automatically, which actually includes giving them sedative medication that's used to treat the symptoms of withdrawal. But if somebody comes in still intoxicated and they get a dose of Valium or a dose of Ativan to treat withdrawal, they're going to be snowed afterwards. And that's happened every now and again. Yeah. So
I didn't think of that.
So when someone comes in, what's the substance you're requesting detox from? Are you loaded on it right now? And what's the degree of use we have to be worried about? Have you ever had bad withdrawal before? It gets tricky. Really complicated cases are the ones where you've got somebody who's maybe retired and they're coming in for some other surgery. Maybe they had a broken bone and they needed surgery to fix it, or they had elective heart surgery, whatever it happens. And post-operatively, they get completely out of their wits, very delirious, very confused, agitated. Vital signs are all over the place. You can become delirious in that agitated way just from having had surgery. Or, and here's the tricky part, if one family member says, well, he's a bit of a drinker. Well, what does that mean? Is this delirium tremens? Is this the really severe case of delirium that happens with alcohol withdrawal? Because you don't want to give a delirious person who's delirious because of the surgery benzos like Valium and Xanax, but you would want to give that to somebody who's in alcohol withdrawal. And so this becomes a particularly troublesome presentation of alcohol withdrawal in a medical setting.
And this could be just they had a social drinking issue,
Right.
but it becomes a problem when you're used to having a cup of coffee every day and all of a sudden you don't have it, you have a headache. It's not that they're alcoholic or they're abusers, that they just need to be honest with their doctors when they're coming in so that we can handle that on the other side.
To leave it up to the patient to be honest is one thing. I mean, some are and some aren't going to be, especially when it comes to substance abuse. Most people aren't going to be. And then that comes into how the questions asked. I remember when I was a trainee, I was guilty of this. And then when I learned about it and I would teach trainees about asking sensitive material, most of them would ask substance abuse questions as a sort of a blanket sentence while shaking their head no. You don't do any drugs or alcohol, right? Shaking their head back and forth as if to say to the person, just say no so we can move on. So instead, sort of reframing it, how much alcohol do you have on a given night? When's the last time you smoked any marijuana? Last time you experimented with cocaine? Just sort of assuming the positive. They'll tell you no if it's no. Just assuming the positive. How many beers do you have? A couple. What, like 9, 10, 12? No, not that many, but maybe like 4 or 5. Instead of asking, how many beers do you have? You're going to get a lower number than if you give them the amplified number. They're more likely to come into a more honest range.
How large are those glasses?
I just have a cocktail. But what are we talking about? 8 ounces or 12 ounces or 16 ounces? When someone presents for detox, you can't put them on autopilot because the medications, especially benzos, especially the sedatives that we use to manage alcohol withdrawal, can themselves be super toxic if they're overused.
And you start out with giving them benzos or Valium and then you titrate them off of that, right?
That's right. Nobody leaves on the medication that we're using to treat the detox. The idea of detox is that it's not safe for you to manage this at home on your own or in an outpatient with your family doctor or what have you, that you need 24-hour supervision in a medical setting to keep an eye on your vital signs, your blood pressure, your oxygenation, your heart rate, and all that stuff.
And that's where the medical intersects with the psychiatry.
That's right. And most detoxes should be 3 to 5 days. I mean, that's pretty much it. And you should be on your way. Even the several times that I've managed delirium tremens, if you catch it early enough, even if they have to go to the ICU briefly, maybe 24 to 36 hours, and they're back on the medical floors, usually by the middle of the following week, we're through the woods. It's really about getting a good history, knowing what you're up against, and being attentive. Every day you come in, what were their scores overnight? How symptomatic were they overnight? Are we right where we need to be? Are we undershooting or are we overshooting? Every day you're reevaluating what your approach is so you don't overshoot, that you're also not undershooting.
So that's alcohol. Now, is it different with opiates?
Yeah, I mean, it is. Why it's different is because, whereas if somebody comes in with alcohol withdrawal and they get on a benzo protocol, that's pretty widely available. If you're coming in for opioid withdrawal, some institutions can give you a methadone taper, some won't. Some will only dispense methadone if you're already in a methadone program. Suboxone, which is the alternative to methadone, arguably a little bit less stigmatized, maybe not easier to obtain, but just as effective, arguably. Most places won't even carry it, and it's sort of tough to get to. So by and large, what you're left with when it comes to opioid withdrawal, which again is considered to be less dangerous, not less comfortable or less uncomfortable, but less dangerous than alcohol or benzodiazepine withdrawal. So you're left sort of symptomatic control. Imodium for diarrhea, muscle relaxants for a lot of the cramping and aches and pains, anti-inflammatories, blood pressure medication can help with some of the adrenaline rebound stuff. Because again, alcohol, painkillers, these are downers, and the withdrawal is generally marked by up kinds of symptoms, high heart rate, shakiness, agitation, anxiety. Things are up. So these anti-adrenaline drugs from the blood pressure, anti-blood pressure category can help manage some of the symptoms. But it's not agonist therapy. It's not methadone. If you do have a situation or if you do have an institution that can get methadone and can detox that way, it's a very, very long-acting drug like a Valium would be. So you're going to expect to dose a little bit higher in the first couple of days, and then that'll sort of markedly fall off once you get them comfortable. And then it's just letting the medication slowly leave the system.
Thank you, Dr. Capote. I would just like to add that withdrawing from alcohol or other substances can be uncomfortable and in some cases present serious health risks. but there are programs available to help individuals get through the process safely and with minimal emotional or physical trauma. A thorough evaluation of a patient's risk for withdrawal complications will help their clinical team determine the most appropriate level of care. Medical detox options include hospital, inpatient, and outpatient settings. Frequently, a detox intervention is performed at a hospital after experiencing a medical emergency. Many hospitals have dedicated detox units where medical professionals are trained to closely monitor a patient's condition and help keep them safe. However, patients are also treated for detox on general medical units. There is also an inpatient treatment option where a patient stays at a residential detox facility for the duration of their detox and receives 24-hour monitoring and care. Some clinics and private physicians offer outpatient detox programs in which a client can reside at home but attend their program or visit their doctor's office on a daily basis. Detox withdrawal symptoms can at times be quite severe, so outpatient detox options are only reserved for those who have been thoroughly evaluated by a physician or other licensed clinician who has specialized training in substance use disorder and found to be at a minimal risk of experiencing a complicated withdrawal. I want to close by saying medical detox is only the first stage of addiction treatment and by itself does little to change long-term use. Although detoxification alone is rarely sufficient to help addicts achieve long-term abstinence, for some individuals, it is a strongly indicated precursor to effective drug addiction treatment. Other therapies like motivational interviewing are excellent in terms of helping somebody get to that pre-contemplative stage to even think of giving alcohol, drugs, anything that's affecting their lifestyle. So thank you, Dr. Capote, so much. I am so grateful for your insight on the medical part and the psychiatry part. I really appreciate it.
Thank you.